Well, now that we've learned how to assess our patient, diagnose them with pneumonia, and start to think about just what sort of pneumonia they have, let's put that all to good use and talk about treatment.
In our treatment section, we're going to cover antibiotics, in particular, empiric antibiotics versus targeted, oral versus IV, for example, and also how to fight resistant bugs. Then we'll talk about not antibiotics, like stabilizing the patient and steroids.
So first step, you diagnose them with pneumonia, you're starting your workup, we need to get some empiric antibiotics going. So this is when your lab tests haven't come back yet, but you just think it's pneumonia and you want to start treatment. Great. So I mentioned outpatient as well as inpatient treatment here because sometimes patients who are admitted with pneumonia to an inpatient service may still, based on, say, their CURB 65 score, actually have outpatient level pneumonia needs. So, if it's an outpatient type of patient, no comorbidities, no recent antibiotics, and a low rate of resistance, you can use azithromycin, clarithromycin, so your macrolides, or doxycycline. And this is just saying monotherapy. But it should be mentioned that in the US, for strep pneumo, greater than 25% are now macrolide resistant, so resistant to azithro and clarithro. So it's not looking good. So if you're in an area where that's the case, doxycycline might be the way to go to start out. Then, if someone based on their disease severity is still an outpatient level pneumonia, but they have comorbidities, recent antibiotic use, or a high rate of resistance in the area, you might actually go right to a respiratory fluoroquinolone. So we're talking about levofloxacin or moxifloxacin. Or you could go right to amoxicillin or amoxiclav, brand name Augmentin, or cefuroxime plus either a macrolide or a doxy. Okay, so that was outpatient. Now let's move to empiric inpatient antibiotics. So these patients are a little sicker. They really need to be in the hospital. So for this group, the convention has typically been to do a beta-lactam, like a cephalosporin, or even a penem or something else, and one of those more atypical coverage antibiotics, like a macrolide or doxy. However, thankfully, in 2015, in the New England Journal of Medicine, there was an article that showed that beta-lactam alone was non-inferior to the beta-lactam plus macrolide strategy. So that suggested that when these people come in the door, you could maybe start them just on ceftriaxone monotherapy without azithro, for example. All that said, that New England Journal study was done in the Netherlands, and so it's still working on taking hold in the US. And, meanwhile, we're all eagerly awaiting the new CAP guidelines from the IDSA, which at the time of this recording are expected to come out in the summer of 2017. And then your third option for inpatient pneumonia therapy, empirically, is just a respiratory fluoroquinolone, and there are pros and cons to that based on side effects and based on changing resistance patterns, because people are using a lot of quinolones, but that is an option too as well. And most importantly, whatever you start, the key is that you're thinking ahead to say, okay, when my microbiome tests come back, when I finish fishing for bugs, how am I going to narrow from what I'm at now? How am I going to step down therapy based on what I find?
But along with narrowing antibiotics is figuring out how long the course has to be at all. And there turns out to be some evidence that you can actually discontinue antibiotics after just 5 days for certain pneumonias. And that's particularly if the patient is afebrile for the prior 48 to 72 hours and has no more than one of the following clinical instability signs, such as blood pressure less than 90, heart rate greater than 100, respiratory rate greater than 24, oxygen sat less than 90%, or an arterial PO2 of less than 60 on room air.
Okay, so let's think about targeted therapy. Name the organism. What organism would you want to cover if you have a patient who comes in, they're homeless, active injection drug use, they're hypotensive, tachycardic from their pneumonia, and they have decreased urine output, they're bringing up really thick, purulent sputum? While there would be a lot to untangle with such a patient, one thing to consider would be empirically covering for methicillin-resistant Staph aureus, or MRSA. I know, right? So let's break it down. What are the reasons to empirically cover for MRSA? First would be patients with known MRSA colonization, such as if they were swabbed during their last hospital admission, or have risk factors for colonization, which is what I was trying to trigger with the injection drug user example. Second, you might want to cover for MRSA because someone is very sick, such as those admitted to the ICU, ventilated, or with septic shock from their pneumonia. Then you want to remember the clinical pearl that influenza viral infection can often be followed by a superimposed staphylococcal pneumonia. So think of the patient who is sick with the flu, starts to get better, then gets worse again a few days later. Finally, think of MRSA when there is some sort of nasty pyogenic pathology. So that's your cavities in the lung, necrotizing infiltrates, and empyemas. Again, the management of a cavitary lesion gets a little more complicated and will not fully be covered in this talk. Another tidbit about MRSA that is as terrifying as it is fascinating is a particularly virulent strain called
Pantin-Valentine leukocidin.
or PVL for short. Basically, a bacteriophage has given these MRSA a special doomsday device, a big molecular pore that they can secrete, which inserts itself into the membranes of unsuspecting white blood cells, causing them to spew their intracellular contents and create a massive inflammatory response.
I'm a macrophage. Oh, Steph Aureus, you guys aren't supposed to be in here. Hey, I'm gonna show you a piece of my mind. Hey, what's that thing? Oh, it's pretty though. Did you make that? Why is it going into my membrane? What's it? No!
The reason to be aware of this player clinically is because it can make young, healthy people really sick really quickly. And because of this, you may underestimate someone's degree of illness or their need for intensive interventions if you used, say, your Curb 65 score when they rolled in the door. So, all that said, when we want to cover for MRSA, how do we do it? Well, at our institution, the most common empiric MRSA coverage used is IV vancomycin. Other options that exist, such as if there is a history of an adverse reaction to vanco in the past, include linezolid, which is probably the broadest covering gram-positive covering agent we use, or clindamycin, which, depending on your local antibiogram, covers some but not all community-acquired MRSA. Hey, as a brief aside, though we think of daptomycin as another big gun for resistant gram-positives, it is not recommended for pneumonia treatment. It turns out that it's inhibited by surfactant, and that multiple trials showed it to be inferior to ceftriaxone in treating CAP. Okay, so you've started MRSA coverage. Now, how do you stop? Well, one option is you will find another pathogen to blame your infection on, based on your sputum culture or some other microbiological testing. But what if, as in many cases, those other tests don't give you the info you need? Now what?
Speaking of, do you remember how often that happened in the EPIC study? That's right, 62%.
Remember back in the diagnosis section when I said we'd come back to the MRSA swab? Well, there's emerging evidence suggesting that if the MRSA nasal and throat PCR screens are negative and no sputum is available, you can narrow to remove MRSA coverage. Next, let's talk about Pseudomonas, who's hanging out in that hot tub over there. So, Pseudomonas, you're another key organism we should think about when managing community-acquired pneumonia. Why should we care?
Well, first off, because covering for me commits you to different types of antibiotics. I can resist most your normal CAP coverage, and that's how I like it.
Oh wow, that's a good point. And we'll walk our viewers through those antibiotics in a little while. But also, isn't Pseudomonas an independent risk factor for mortality in community-acquired pneumonia?
Aye, and I'm proud of it.
I see. And in the broadest sense, who are you most likely to infect?
Oh well, I'd say I have the easiest time setting up shop in folks with underlying lung disease for one thing. That being especially cystic fibrosis and bronchiectasis, but also bad COPD. Also folks who pass through healthcare more often, that way I can find my way to them. And then of course, people on the ventilator are easy prey.
Wow. Anyone else?
Well, sure, the list goes on. Even if a person has recurrent pneumonias with other organisms in the past, that increases the risk for me getting in. And then you got your immunosuppressed, but even inhaled corticosteroids will do the trick.
All right, Pseudomonas. Well, thanks for making us aware of those risk factors there. And I think our viewers should know that according to a recent article from the journal Chest, patients with Pseudomonal cap are more likely to be older, more likely to be male, and they're more likely to present with a higher respiratory rate, so more tachypnea, and worse respiratory failure, but actually less fever. Who knew? So when we want to treat for Pseudomonas, how do we do it? Let's talk about some of the traditional antibiotics. First, we'll talk about the beta-lactams. First of all, there's piperacillin and ticaracillin, your anti-pseudomonal penicillins. And at many institutions, piperacillin is used with a beta-lactamase inhibitor, tazobactam, brand name Zosyn. Piperacillin tazobactam, represented by this piping plover, with a taser on its head. And this serves as a great reminder that if there is not a resistant organism like Pseudomonas, using this drug is, well, plover kill.
It be good to be Pseudomonas. Resistant to air. Oh, look, a little birdie. What's that thing on its head? Oh my god, is that a taser? No.
Okay, that happened. And then there's the cephalosporins, and in particular ceftazidime is one we use here a lot. And you'll notice the Taz for taser is in there too, easy to remember. And then finally, the carbapenems are a final class of beta-lactams that are very broad spectrum, including having action against Pseudomonas. But wait, here's a question for you. Do you remember which penem does not cover Pseudomonas?
This pen doesn't work on Pseudomonas. Ow! Forget it.
There you go. It's ertapenem. Just remember it's frustrated. I wish I could cover Pseudomonas. Then moving away from the beta-lactams and over to some other drug classes. We also have the fluoroquinolones, and in particular ciprofloxacin will cover some Pseudomonas. And then finally we have the aminoglycosides, especially tobramycin, as well as good old-fashioned gentamicin. Okay, so what do you do with those antibiotics? Now, if you're like me, you've heard murmurings, you've heard scoffs, you've heard champions and opponents to the idea of double coverage for Pseudomonas. So what's the deal there? Well, there's no perfect study that has confirmed very confidently whether double coverage for Pseudomonas is the way to go. It seems like generally what the studies have shown is if the patient is very ill and your suspicion for Pseudomonas is high, you should initially double cover because it might improve mortality in that initial septic shock illness period when they first come in. Okay, so if you're going to double cover when they first come in the door because you say, hey, they're super sick, I'm super concerned about Pseudomonas based on their risk factors, the way to do that would be to combine your first agent being an anti-pseudomonal beta-lactam, so that's going to be like we talked about, like your piperacillin tazobactam, or your ceftazidime, or maybe a carbapenem that's not ertapenem. And then your second agent, you want it to either be an aminoglycoside or a fluoroquinolone. So most typically it's the aminoglycoside, but you have to be okay with the risk factors, right? You have to be willing to take the risk about the renal toxicity, the ototoxicity, and so on. And all that said, if you're going to double cover, even if it turns out to be Pseudomonas, you want to stop the double coverage and narrow to a single anti-pseudomonal agent after 3 to 5 days. So let the microdata come back, see what seems to be working or not working, and go from there. Finally, for our antibiotic treatment section, focusing on specific organisms, I want to circle back and harp on Mycoplasma just a little bit longer. So, as you recall, Mycoplasma does not have that typical cell wall. It's this little bacterium with a weird membrane, sometimes intracellular, and so it makes sense that your antibiotic choices are not going to be things that target the cell wall like beta-lactams, but rather things that have intracellular targets. And that's why it makes sense that historically people would get walking pneumonia from Mycoplasma. They'd present to their primary doctor and go home with a course of azithromycin. And it worked. Azithromycin, represented by these blue mice, used to valiantly and successfully destroy the Mycoplasma. Sadly, nowadays, an increasingly common picture looks more like this.
Oh yeah, I so got this. Watch this.
Yep, they fall flat. A recent study that looked at different institutions around the U.S. found that Mycoplasma azithro-resistance is now up to 13%, and it's already much higher in other parts of the world. Fortunately, in that study, When they looked at sensitivity to tetracyclines like doxy and respiratory fluoroquinolones, those were still 100% for all isolates. So I would say the takeaway is that in the outpatient setting, or initially, if someone comes in with walking pneumonia, you could still consider azithromycin your first line, but just keep in mind that if treatment fails, you have to consider that you may have a resistant organism on your hands.
Okay, so we blew all of our budget on that last animation, so now let's just finish up with the treatment section by talking about things other than antibiotics that you might use when you're treating pneumonia. So one piece that's going to come up right away and might already be started for you in the emergency room is stabilization, right? So you need to do the general resuscitative stuff. You want to give them IV rehydration. You're treating sepsis, so it's going to be usually bolus crystalloid, so not albumin for most patients, and not maintenance fluid infusion, but really bolus fluids. And of course, you want to look out if they have CHF, especially if they're one of these patients where you're not sure if they're coming in with pneumonia or CHF exacerbation or what. And of course, you might give them supplemental oxygen. Most commonly, that will be nasal cannula, but if they're sicker, it might include the non-rebreather, venti-mask, CPAP, BiPAP, or intubation, of course, then requiring higher levels of care. Then you can ask, is there a role for steroids? And yes, I'm talking about even someone without underlying lung disease like asthma, COPD, or ILD. The use of steroids in straight-up pneumonia. And this has been some interesting literature that has come out recently. So what did they find? So the studies seem to show that the sicker the patient, the more benefit there might be from using steroids. But there may be some benefit for all hospitalized patients with pneumonia. You just have to watch out for contraindications, which I'll address. One caveat here is that the immunosuppression issue does come into play, particularly when you have infection with certain organisms. Specifically, if you have signs of influenza virus or concern for aspergillus in the person's lung, the steroids become contraindicated. Other than that, if they have low cell counts, you're concerned about neutropenia or things like that, those might be other reasons to avoid steroids. And if you do think your patient, a hospitalized patient with CAP, who is on the sicker side, would benefit from steroids, these studies suggest a burst, such as a 5-day course of 50 mg daily of prednisone, and then stop. And at last, we're ready to tie this all together with the write-up. So, for our assessment, your one-liner can include relevant comorbidities, such as, "This is a 65-year-old man with a past medical history of diabetes, alcohol use, rheumatoid arthritis on chronic steroids, multiple recent hospitalizations," etc. And you can see how already with that information given, your audience is going to have certain organisms and management choices coming to mind. Then you characterize the clinical syndrome like always, presenting with 5 days of productive cough and fever. And you can include words to assess the distribution. So is it lobar, multilobar, diffuse, and which lobes? Then you want to conclude the one-liner with your top diagnosis. Most consistent with community-acquired pneumonia. Then this gets into style and how much you want to say or write with your particular audience in mind. But assuming you're expected to thoroughly explain your reasoning, here are some things you might say next. You can put a hypothesis down about the type of organism, such as if someone has this thick, purulent, productive cough and a focal or lobar infiltrate, you might put your money down on typical bacteria most likely. And if you are telling them that your patient has had this hacking, dry, nagging cough for 2 weeks that didn't respond to a beta-lactam, well, then maybe you're going to suggest that it's most likely atypical, like mycoplasma. Your thoughts about the organism will nicely transition into your rationale for further workup and treatment, and shows that you really have thought through your case and are thinking beyond just a one-size-fits-all pneumonia treatment plan. Scoring systems. Curb 65, likely the most useful. You can also note how many signs of sepsis or clinical instability are present, also in order to help guide antibiotic duration. Now let's go on to the plan. So first, resuscitative interventions, because you don't want to get so excited about making your ingenious antibiotic choices that you don't do the basics like those IV fluids. There's an example there of a common line from an H&P for someone who has already gotten some fluid downstairs and on your assessment is normotensive and appears euvolemic on exam, so you decide to just encourage PO for now. Then you consider need for oxygen like we talked about. Then, thanks to this whole presentation, you are going to have some great idea of what antibiotics to start for the patient. And depending on style of your write-up or presentation, you might give your thoughtful, justifying rationale for your antibiotic choice either here or above in the assessment as mentioned. Sometimes this may include saying the patient needs broader empiric antibiotics for now, but also with a suggested plan for de-escalation based on further testing or clinical improvement. Also suggest likely duration of antibiotics in general. Remember that those who stay very clinically stable may be done after just 5 days of antibiotics. Next, you may want to get additional diagnostics to characterize your suspected pneumonia. Maybe they are really sick or meet another indication to check blood cultures, because remember, you don't do this for all pneumonias. Maybe the patient is making some legit sputum and you want to grab a culture on it because they are a host with risk factors for less common organisms. Or maybe the whole pneumonia thing is a soft call, so you might consider procalcitonin and/or a viral DFA PCR nasal swab to tip you one way or the other. I will emphasize one final time that the astute clinician will not order all of these tests every time, but only when they are indicated and will actually be likely to affect management. Speaking of tests you should do judiciously and not every time, think about additional diagnostics to reassure rule-out of other diagnoses, such as CHF exacerbation or PE. You know, even though you just watched a pneumonia video more recently than a CHF video, doesn't mean your patient's body did the same. But seriously, these alternate diagnoses are important things to circle back to during your continued care if the patient doesn't respond as expected. Next, corticosteroids, which are likely underutilized based on evidence. So your patient may meet the current recommendation for a 5-day prednisone burst. Oh, here's a fun one. Should you re-x-ray your patient to confirm resolution of pneumonia with your antibiotics? Nope, not really. Your chest x-ray findings for pneumonia are going to take a few extra days to bloom after symptoms start, and then those x-ray abnormalities are probably going to hang around a whole lot longer than symptoms, like weeks. The only reason to re-x-ray is a new change in clinical status, like a sudden worsened hypoxia, for example. But in the outpatient primary care setting, or your average stable inpatient pneumonia, no repeat x-ray needed. Another important exception to keep in mind is if you suspect a post-obstructive pneumonia associated with a lung tumor. So this is going to be people either with recurrent pneumonia in the same lobe or with coexisting constitutional symptoms concerning for cancer. Those people should get a repeat x-ray probably at 7 to 12 weeks out to confirm resolution. Okay, then to wrap up, consider some odds and ends like counseling on pneumococcal and influenza vaccines, which can be given prior to discharge. And most importantly, smoking cessation should always be on your agenda. Well, it's been an absolute pleasure to take you through this introduction to the inpatient management of community-acquired pneumonias. I'm Brian Brown, joined by Sarita Soares to bring you this installment of the Yale20 series. Hope you've enjoyed.